Hi, everyone. This is Lynn Crawford with Hope Dementia Support, and I am honored to have this wonderful panel of hospice and palliative care experts here to talk to you a little bit about what they do and to answer your questions. So as questions come up, if you will either put them in the Q&A or in the chat, we'll make sure that they're answered. And I'm going to just let everyone introduce themselves. And I think we will start, according to my screen, we'll start with Amanda.
Hello, everybody. I am Amanda Eastman, and I'm a social worker with Kaiser Hospice. And to describe a little bit about the hospice program, and I'm sure we're going to go in a lot more detail about hospice, but basically, it's a program of comfort care focused on patients who have a diagnosis or a prognosis of 6 months or less life expectancy. And then it's home based. So the nurse, it's a team of a nurse, a social worker, a chaplain, and a bathing aide that can go into the home. And the focus again is all about comfort care, no longer about treatment and pursuing different kinds of treatment for an illness. And then it's a Medicare benefit. And so as far as the social worker, what I do on that team is I'm there for emotional support to patients and their families. And I'm also there to talk about end-of-life planning, information and resources, things that I try to find to help a patient and a family that with things like caregiving resources, help with all kinds of concrete services like food, anything that a patient and a family needs. I try to figure out if there's a resource and how we can access it. So I'll let the next person go from here.
Thank you. So Michael. No volume.
I am with Peace Health, Home Health, and Hospice. I am the community liaison for that program, and I forgot palliative care. So community liaison for home health, hospice, and palliative care. And really my main job function or job description is community outreach and education. And always more than happy to talk to anybody one-to-one or in groups about our program and about just hospice and palliative care in general.
Thank you. Dr. Tang.
Hi, I'm Linda Tang. I'm a physician with Vancouver Clinic in the Department of Palliative Medicine. I do 100% outpatient palliative medicine. I see patients in consult and referrals for dementia as well as other chronic illnesses.
Thank you. Mary Buckland.
Hello, I'm Mary Buckland. I'm an inpatient palliative care nurse practitioner here at Legacy Salmon Creek. I also I am the founder of Mobile Healthcare Providers Northwest, where we do on-site care, mostly primary palliative care, but primary care for those individuals that live in memory care units, and it's very difficult and taxing for them to go to a traditional medical office visit.
Thank you. William.
Good evening. I'm William Fogelman. I'm a community liaison with Eden Hospice Services. My primary duties with our company is to do community outreach, do community education on hospice services, as well as meet and help assess patients or clients that are wanting to come onto services for hospice, and trying to meet one-on-one to see if the hospice focus of care is the direction that our patients and families are ready to go through. So really working through their questions, your questions as a community to see which line of services is what's best fitting for you as a family at the time that we have our discussions.
Thank you. So I would like to run through the questions in our title. And the first question has to do with what is it? What is palliative care? What is hospice? Are they different? Are they the same? Can you explain that to us? And I think I'd let our palliative care folks speak first. So Dr. Tang and Mary Buckland, can you pick up that question and run with it?
Yeah, I will share the infographic. Picture paints 1,000 words, and then hopefully Mary can fill in any gaps that I miss. So let's see, where are we? Everybody see that?
We can see it. Can you make it a little, yeah.
Yeah,
Perfect.
let me do. All right. So I want to draw your attention to the idea that life is this blue line right here: time, age, disease, progression. So this is from birth until natural end of life. And so in a person's lifetime, they are on different teams. So right now, if you've ever been a patient anywhere, you're on team A. And team A is designed to diagnose, treat, and cure. So traditionally, you would have a primary care team, practitioner. You might have a specialist team. You might go to urgent care. You might go to the ER or the hospital. Palliative medicine is a specialty as part of team A. And what they're doing is in this specialty, they're seeing advanced chronic illness. So your dementia, your CHF, anything that is advanced and progressive and chronic. And they do symptom management. So in a dementia patient, it might be agitation, loss of appetite, insomnia, constipation, hallucinations even. And then other things we do is we talk about goals of care. Maybe there's family and caregiver distress. Maybe there are frequent admissions to the hospital. We talk about advanced care planning. Do you have a power of attorney? Does your dementia patient family member need to transition to a higher level of care? All of this purple is under the auspices of this specialty. And Mary's work in the hospital is all of these things, except it's in an acute situation, which we're grateful that Mary works in the hospital, but these conversations are not ideal when the ceiling is falling down and things are going awry. So we're trying to capture the whole spectrum of outpatient and inpatient. So usually patients, when they enter with palliative medicine, they're on this side of the spectrum on team A. Obviously, over the course of someone's life, their disease is going to progress in a more serious manner towards an end stage or terminal place. And so then you want to decide to switch teams, just like basketball or dancing. Team B is not focused on diagnosing, treating, and cure because you already know you have dementia. You already know you have stage 4 cancer. So what they're looking at is a less than 6 months prognosis, and these diseases are at a terminal end stage point. And the goal is for the family and the caregivers and the patient is comfort. They're not interested in another PET scan or a clinical trial or a transplant or anything aggressive. They're looking for a natural, dignified, comfortable end-of-life transition. So when the family and the patient is ready for that transition from team A to team B, then hospice referral is given by either primary care team or a specialist. They make a referral to hospice, and then you switch teams. What would you like to add, Mary?
Well, I would agree that many times when people land in the hospital, if these conversations haven't taken place, it can be very difficult because we're trying to get up to speed. And your analogy of the ceiling is falling in is so very true. And I think one of the other things that we do in the inpatient world, all of those things you mentioned are absolutely spot on, and we are certainly introducing those things and those issues into the conversation. But the other thing that we do a lot of, if we can get a person's condition stabilized while they're here in the hospital, is we are, in the absence of a crystal ball, trying to anticipate this is where you are now, this is where we think you might be in a couple of weeks, this is where you might be in a month, and really trying to help lay the groundwork and give people the roadmap of this is where we think things may be going so that they can have that information moving forward with the hope that they continue with those conversations when they get back out into the outpatient world. Um, and so we can try to relieve some of that shock and awe that can happen when the ceiling is falling in down on them. Because it is very difficult when we have a patient coming in and they haven't had any of those conversations, and the approach can be very reactionary versus proactive. And ideally, any approach, if we can do it proactively and really dive in and talk about these issues before a time of crisis, is the best time for people to be clear-headed and to put a really good plan into place. That would be the only other thing that I would add to that.
So a question related to that, I know that sometimes people come into the hospital without having had any advanced care planning. So is that something that is part of the palliative care inpatient? I know it is for sure for outpatient.
Oh, absolutely. Many times it's just trying to figure out who the person's people are in regards to decision makers, support people. Where do they live? What kind of, supports do they have in place in the community? Do they have any? Um, and trying to determine else should be involved in who should be involved in the decision making and the support of this patient, as well as, have they ever had conversations with that person about what they would want at the end stages of disease or if diseases were advanced. So we are always very curious and looking into who are the people that need to be involved, what is important to that person. And advanced care planning it's very common for us to say you haven't completed a durable power of attorney for healthcare, but we have the forms here, and you're telling me you want your neighbor who's been your neighbor for 30 years to be that decision maker. We can do that here. We can formalize that for you here, just as an example, or completing a post form, those type of things, just to really make sure that we're trying to address all of those issues.
Is there a time that hospice is included in that advanced care planning? At least the
Oh,
conversation related to that?
absolutely. A lot of times we will have a consult where maybe that person isn't hospice appropriate right now, but again, that anticipatory guidance on where we think things are going, and how things are progressing. It is not uncommon for us to say, we don't think it's time for hospice now, but would we be surprised if things continue in the next few weeks to months that it would be time to have that conversation about hospice? And we talk to them and tell them that we think that may be a conversation that's coming down the road. And one of the things that we try to do is offer up a hospice informational visit, where when they get back home, the hospice team can reach out and talk about their services so they can have those questions answered and understand the hospice philosophy and how that works. Of course, we're happy to explain that while they're here in the hospital with us too, but many times again we are reacting because of an acute illness. So sometimes when the dust settles and people can be more attentive to a conversation, we like to offer that when they get back home and things settle down a little bit.
Okay. So Michael, Mary is at Legacy. What is there at Peace Health? Is there inpatient palliative care at Peace Health? You're on mute.
Yes, there is. We've got a great team there. The team leader, her name is Lynette, Lynette Paulson, and the way it's set up at Peace Health, when the doctor comes in and has made the determination that a patient will be or would be appropriate for palliative care, a palliative care consult will then be sent to the palliative care team. And then within a day of that referral, then somebody from the palliative care team, which it could be a nurse, it could be a social worker, or it could be one of the social worker, nurse, or a nurse practitioner, and one of them can come in and then do their assessment and talk to the patient, just like Mary and Linda were saying, and do that assessment and determine what the needs are for palliative care. And a lot of times after the palliative care consult has been done, then depending upon where the patient is, we'll get a referral. The hospice team will then get a referral from the palliative care provider.
And, I know Vancouver Clinic has outpatient palliative care. Does Peace Health have outpatient palliative care?
Yes and no. So the reason why I say yes or no, up until a few months ago, the answer was yes. We had an outpatient program. And then for a number of reasons that actually that part of the program was put on hold until we could do some reorganization. And then just recently, and we haven't made the official announcement for the community, we've been trying to announce it kind of step by step to certain community partners that we now have that option again. There is an option of having an outpatient palliative care program, having again, nurse practitioner, social worker, nurse come out to the individual's home. And it's a consultative program in the sense that, as soon as we get the referral, within a week or two, our team will come out to the patient's house and make the determination of what the needs are. A lot of it's that advanced care planning. And then from the advanced care planning, if symptom management needs to take place, then they'll make arrangements or will add additional visits. But usually it's just 2 to 3 visits off the top, just to make sure that the goals of care are in place, that there is a plan in place, advanced care directives are in place, the pulse form is in place. Those are important things. When I worked in the hospital, one of the huge barriers that we would come across is a patient would come in and we actually didn't know who the POA was, the power of attorney. We didn't know who the person, especially with dementia, we wouldn't always know who was making the decisions. And a lot of times, there was a spouse who did make decisions, but then after talking with them, we realized that they had some dementia issues as well, and perhaps weren't the appropriate person to talk with. And our hands were tied because there was no documentation saying somebody else is a decision maker. And so having, palliative care, having, the paperwork in place, the advanced care directives, who's good, the POA that's been identified, that is so important just from the hospice perspective, because that can be a barrier for hospice as well. But yes, we are starting to have a return of the outpatient program.
That's good news. Amanda, how about Kaiser and palliative care?
Yes, Kaiser does have a home-based palliative care program, much as what Michael described, very similar, where the nurse will go to the patient's home and will kind of coordinate with the patient's primary care provider. And we do have a palliative care doctor with the nurse and then the social worker. So the team for the home-based palliative care is the social worker, the palliative care doctor, and the nurse. And we all are involved with home visits to the patient to help reduce the amount of visits they have to do to go out and get medical appointments. And also to help with resources as needed and to monitor symptoms and coordinate. Yes.
Oh, thank you. So we've gotten several questions here about, okay, how do we get on palliative care? How does that happen? I would ask all of you, how does that happen?
Well, with Kaiser, usually the patient's primary care provider will connect with our palliative program and make the referral. And from there, we will set up an appointment to go out to the patient's home, do an assessment, and see how we can help.
And that's pretty much the same way for Peace Health as well. We need a referral from the provider. Now, if a patient is actually in the hospital, then the attending physician, the hospitalist, then they too can make that referral.
And at Eden, we provide a palliative care program only in the Cowlitz County area, and we operate much like Kaiser does because we're contracted with Kaiser for their PAL program in the Cowlitz County.
Oh, that was good information. I didn't know that.
Yeah, we try to make the home-based program in Cowlitz since has such a small amount of care in that community that we are able to contract for palliative care with Kaiser insurance clients in the Cowlitz area to provide those services at home.
Is Eden Health looking at expanding that into Clark County?
Hopefully in the future, yes.
And just to add on to what I was saying earlier, and I'm glad William said that, our home-based program is just for Clark County right now. We're not back up in Cowlitz yet.
So here's a question about who would do that assessment for palliative care. So it sounds like it depends on what your insurance is.
Well, as far as the insurance, so the individuals that would come out for our program, and it depends upon really the diagnosis and what's going on, but it could be the nurse practitioner, it could be the nurse, it could be a social worker, and it just depends upon really the order that we get in the diagnosis.
And Dr. Tan, oh, good.
If the patient has any touch point with Vancouver Clinic, they can get a referral to see me. So sometimes it's a patient or their family member calling their primary care, if that primary care is part of Vancouver Clinic, and saying, I would like a referral to palliative care. I want to say almost 100% the PCP will then place the referral if it is at the request of the patient or the family member. If you don't have a PCP, but you see one of our specialists, you can go through that route. And I think for commercial insurance, you can just call directly and then make a request. And we should still be able to see you regardless of having a PCP or specialist at the clinic. I hope that answers the question, because I have I have a full week of clinic. I'm 100% outpatient, so I'm not limited to half a day or 2 days. I do Monday through Thursday.
So let me clarify that one more time. You do not have to be a Vancouver Clinic patient in order to see you if your insurance will cover it.
Yeah, I think right now it's commercial insurance that we can accept without an internal referral. Everything else needs an internal referral by PCP or a specialist at Vancouver Clinic.
Okay, thank you. So here is a question. I am or have been my mother's caregiver along with her husband, 92 years old, 10-year history of dementia. She sees a geriatrician. She cannot see the doctor until March. Is it possible to get palliative care into home? Does she need a primary referral? Her husband needs the support. It would be great to have someone else make the assessment. And then the tack on to that question is, Mary, with your mobile care, can you see palliative care contact at Touchmark?
Right now, we aren't offering services at Touchmark, unfortunately. I would wonder, I would openly question if the geriatrician might be able to send that referral request out for palliative care, given that the primary care provider appointment is down the road. Sometimes we do see geriatricians who are very closely involved in those with dementia, and our seniors do send referrals out. I would think that would probably be the quickest way to get that done, and that would be my recommendation.
Thank you.
Yep, I agree.
Another question, are visits with the Vancouver Clinic palliative care all in the office, or are they ever in the home?
So I think a clarification that's important to point out is that as a specialist, I don't have like a team the way hospice does to go into the home. It's like you see your cardiologist at the office, or you see your cardiologist through the video visit telemedicine. So I'm a specialist too, so I do all of those things, whether it is a video visit or in the office. If you're asking for like in-home care, you have to be asking yourself, are you looking for home health? Are you looking for caregiving support? What Mary is doing, I think, is she's a practitioner coming into someone's house. So that is rare in this community to be able to do home-based palliative care. I want to say Mary's the only one that does that. I don't have the capacity to do home visits and travel around Clark County because I'm a department of one. I'm needed in the office. So if you were to look at a map of the United States, there are some cities where they do mobile, like ambulatory home with a nurse and a palliative physician that makes house calls. So most people come to my office and they say, what services do you provide in the home? And they're thinking I'm home health, or I have caregivers lined up in my office that I just, shell out to the community. So that clarification is important to understand.
A couple of other questions related to palliative care before we move on to hospice. And one of those is, how can palliative care benefit someone who has dementia? Why would I want my loved one to be on palliative care?
I think, of course, depending on the type of dementia and where they are in the disease process, a palliative care provider could really help walk alongside that person in watching the disease in its progression, how it's presenting. Also have those very important conversations about what I always use the analogy when we're going down this road with somebody in their disease process, we're coming to forks in the road, and talking about the options that for treatment or intervention that could be offered, but also what the risk and benefit of that would look like. And many times what we see here in the hospital is that person with dementia ends up here in our hospital and then ends up, very delirious, because that's very common to occur when people are very sick and they have dementia. And if they had a palliative care provider involved, some of that anticipatory guidance could include how to avoid hospitalization. So if an illness were to occur, how could we support them in the community and their living without the potential of being hospitalized and really coming out of the hospital sicker and at a much lower functional and cognitive level as a result of a hospitalization that the intent was to make them feel better, but many times it's a manifestation of how the disease progresses and it presents itself. And really also that palliative care provider anticipating, that when that person is at the end stages or nearing the end stages of their disease, talking about hospice so that rather than again, that reactionary approach of sending somebody to the hospital in crisis and then opening the can of worms of all these other consequences of being admitted to the hospital, having a hospice team come in and admit them and support them in their day-to-day living, and understanding that people, when they're put on hospice earlier, we know that they live longer because their symptoms are better managed, because they're under less physiological distress, and that their quality of life is so much better. So that is where I would see that it would be very beneficial to have a palliative care provider walking alongside somebody with dementia as it progresses. And again, depending on what type of dementia as well.
And one thing I would add to that is, if you consider the team who would actually come out to the home, one of them is the social worker. And, the social worker, they really have two functions. One is that psychosocial components and just discussing about the impact, the emotional impact that having a loved one with dementia, the cost of that. And I'm not talking about physical or cost and money cost, but the emotional cost. And then in addition to that, there's a lot of community resources, and not everybody is hooked up or established with Hope Dementia. And there's people out there who still don't know about it, right? And so having somebody who is aware of that, guiding somebody in that direction, or sometimes it's the wife who has dementia and the husband, isn't a great cook and needs Meals on Wheels, just as an example. And so that's an example of a community resource that's out there that the social worker can help set up or guide the family member to that.
I'm gonna share 4 slides. I don't know. Did someone raise their hand?
Oh, that's all right. Go ahead and share your slides and it might answer the question.
Okay. So we had talked about advanced care planning, so I just kind of wanted to summarize what Mary was saying and the panelists were saying. So when we talk about advanced care planning, think of this as the beginning of 18 years old, and this is towards crisis. So at advanced care planning at 18 years old, you need to be thinking like choosing a delegate, like a power of attorney, because 18-year-olds and above drive. Most of us drive. And so the idea is like, well, what if something happens? What if there's traumatic brain injury? So you want to have a delegate. You want to have a power of attorney. That's bare minimum, very basic, 18 and above. It doesn't matter if you are dying or not. 18, you should be starting some advanced care planning, especially a DPOA. Then as you progress in your age and disease, you want to start talking about goals of care, which is still part of advanced care planning, but it's more specific to the illness. Now that you've had this heart attack, now that you've had this stroke, now that your dementia is getting worse, then you have to start looking at fears, trade-offs, what's important. What if I need dialysis and I have dementia? What if I need a feeding tube and I have dementia? What if I have a stroke and I have dementia? So dementia is slow, but it is pervasive. And so when you have dementia in the background and then you have an acute event, it really challenges the quality of life. And so if you prepare with the triangle upside down like this, then eventually when heaven forbid you have to go to the hospital and you see the inpatient team, then it's decision time. It's in the moment, and it's all guided by when you were 18 all the way until 93 if you live that long. And then you start asking, this is happening now, what should we do? And what Mary and I have found when I did inpatient was the patient is not present to tell you what they want. It's the daughter, it's the spouse, it's the children, it's the caregiver that's tasked by the ICU, by the ER, by the hospice, and saying, well, what were her wishes about this surgery? What about antibiotics? What about going to the ICU and being on a ventilator? And so it's like you have to know that this person's vision of their quality of life. That's why you want palliative care and advanced care planning early on, because that window of cognition and that window of clarity is going to close. Even though the patient's still alive, they're probably stable, but if they can't voice to you what their limitations are or what makes a good day for them, then we're all trapped and stuck. And that's what Mary's talking about. That's when things are falling from the ceiling and we need to make a decision, but we have no roadmap on this journey, on this hiking trail in order to get us home. So the next slide is, this is a medical trajectory of dementia. So you might look at this and say, where is my dementia family member or someone I know on this map? It starts with 1, it goes all the way to 7. I highlighted 7C as in cat because that is the entry point of hospice. When your patient gets to 7C, however fast or slow, or if you get to 7C, you are on paper eligible for admission, but there's a gray zone in that. And I won't get into that right now. We'll probably talk about it in the hospice section. So this is a nice map because the top talks about how slow, pervasive, but slow is the emphasis of how dementia travels over time. It's, for lack of a better analogy, it's like watching grass grow. Cancer is much faster. The bottom graph is talking about anyone who has dementia, but also has other diseases like heart failure, COPD. And what these little valleys and bumps are is when they're hospitalized. So if you have dementia and you have aspiration pneumonia, you have a stroke, you have a heart attack, you have COPD, and you're going in and out of the hospital, think of that trajectory of decline. It's much faster than the isolated dementia decline. But most of my patients have both of these combined. So what I do is I combine the two maps of prognosis and trajectory to help the patients and their families see the trail map on the hike that we're about, to go on, because it is a guided, a walk. And the palliative team is basically your trail guide. We draw the map, we show you the map, we get to the trailhead and we say, what are your goals? What's important to you? Then I can recommend trail A, B, C, D, E, F, G. And then you can decide, do you want the ceiling falling down and go down path A, or would you rather have a smoother walk towards the waterfall? And because I'm the guide, I don't push you in any direction, but I do assess what's important to the patient. And that's why they have to be speaking. They have to be cognitively intact. You don't want to wait 10 years later when you've lost that window. I think this is the last slide. So I just showed you this. This is the same thing. It's a little bit busier, but you see the line again, the brown and the teal at the bottom. The top one, that blue, that's cancer. We're not going to talk about cancer today. And someone was asking the question of, when do you involve palliative care? So just follow me because it's pretty busy, but if you follow my words, you'll understand this. So start towards the left where it says low and high. And then that is telling you about function, right? So function is low at the bottom, function is high at the top. And then if you follow from the left to the right on the bottom, it says time. So this is progression of disease. This is loss of function. So that makes sense, right? When people are first diagnosed with like COPD, their function's pretty good. But if they keep going into the hospital like this, their function is going to decline over time. trajectory 3, which is the teal line, that's dementia. And so their function starts off, pretty okay, but then over time, it's slowly like grass growing. It just declines and goes towards this area. So this whole area is called active treatment. Remember, I talked about team A. So in the beginning of a disease, active treatment is huge. Like you're looking for stuff to fix. You're looking for colonoscopies. You're looking for intervention. And at that point, palliative care hasn't begun yet because look, it doesn't begin until the disease advances. So if you look at the beginning of this red here. So then over a person's time, function declines, treatment is becoming less effective. This is end of life. So everything that we do is under the gray. So as you can see how the two things are colliding, and you can see the active treatment starts declining, right? Because if you're going to approach end of life, there's no reason for you to get chemo 5 hours before you die. There's no reason for you to undergo a very serious surgery 6 months worth of life left, because it could actually curtail that 6 months. So hopefully you can take a picture of this and then look at it more thoroughly. I don't want to take up platform time, but this is a very good map. If you do study it a little bit closer, it'll come to light when to get palliative care, why to get palliative care, and where are you on this trajectory. What questions do you have from the slides?
Yeah. Well, one of the questions that I really think that you answered, but I will double check, is what determines the point at which the person would need to go on palliative care. And I really think that last slide described it well. And then, of course, the next question would be, can you stay on palliative care forever? Or should you go on hospice?
Yeah, I can answer that. It gives me shivers to answer this. Let's see. Let's go back to this slide here. Oops. The answer is yes. If you would like, and I'm going to be very blunt because it's 7:13 p.m. and the filters are gone. If you want to go up in flames, yes. Can you see this?
Yes.
Okay. So I'm going to close this so you can zoom in a little bit here. All right. So this little thing down here, if you stay on team A, yes, you don't have to go through this door. You can go around the door and stay on team A forever. What does that look like? You're intubated. You're on a feeding tube. You're living in a long-term acute care facility on a machine. You're in the vegetative state, prolonged life support. So if you don't want to have dignity, less suffering, comfort, being at home in your pajamas with your family, your cats, whatever, yeah, you can stay on team A forever. And there are people who do that. I have not seen it done well. But some people have cultural beliefs, religious beliefs, personal beliefs that say, I will never, 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 never give up. The majority of my patients, though, do not do that. 99% want to go through this door. And it requires that gentle but realistic hand-holding approach of, I know you wanted to go down trailhead A. I know you want we all end up at the waterfall, right? I know you wanted to go on road A, but you just broke your ankle and now you got bit by a snake. Road A is not good for you. And you might be stubborn and say, I don't care. I still have one leg left and I'm just going to hobble to the waterfall. Well, as your tour guide, I can't stop you. But the rest of my patients were like, you know what? It was a good run. Trail A was interesting, but I'm going to take a detour and let me go on a different path. Let me do B. Let me just cut over to B. B is a little bit easier. I don't need to see more snakes. I don't need more hills and rocks and things in my way. I just need to get to the waterfall. And then I guide you and I say, okay, let's do this. We are together. I support you. I respect you. I think that's a good idea. So that is your answer.
And that allows people to stay on palliative care and yet avoid some of the very dramatic things that we have the ability to do.
If you stay on palliative care, you're also staying on the ER side, the urgent care side, the hospital side, because it's not like at 3 a.m., if you have chest pain, someone's going to come to your house and assess you. At 3 a.m., chest pain equals hospital, aspiration pneumonia. So there's a certain point where you're like, why am I still with palliative care and my primary and my cardiologist, and my neurologist? Why am I still on this team? There's nothing more that I need from this team. It's not that I don't love them. It's just I don't need any more of their toys. I don't need their PET scans. I don't need another lumbar tap. I don't need another hospital admission. It's been the 6th one in 3 months. I'm not getting better. My body is fighting this. My body wants to go home the natural way. So because we have willpower, we can either listen to our bodies or we can just take our brain and say, I don't care what you think. I still have one leg left. Let me hobble. And I'm thinking, you need the hospice team at this point to carry you towards the waterfall. So you wouldn't want to stay on palliative care. You want to make a transition to Team B when you're less than 6 months, you're focused on comfort. You don't want to go up in flames.
Perfect. Thank you. So now I have some very, very specific hospice questions that I think are really related to things that we've talked about in our groups over the last few months. So you hospice folks, don't feel like I'm putting you on the spot, but I'm putting you on the spot. This is a simple one though. What is GIP? What does it mean?
GIP is short, it's an acronym for general inpatient care, general inpatient. And general inpatient is generally kind of, well, we usually see it in those final hours to days of life. And there's multiple symptoms that are out of control. It could be, and keep in mind, now that we're talking a little bit about hospice, the big thing for hospice is we do symptom management. That's really our primary focus. It's comfort care. And so we look at pain, anxiety, respiratory distress, nausea, maybe secretions in the mouth. But when somebody qualifies for general inpatient, or at that point, usually we see a symptom that's out of control. We usually see pain or anxiety, and we need the team. The patient needs 24-hour care. Usually hospice takes place at the home, and the nurse visits, and I won't get into the details of that, at least not yet. But usually you see the patients at home, and home could be a regular house, assisted living, adult family home, essentially the abode, the humble abode. But if a patient is and we usually see it at the hospital. If a patient's at the hospital, their pain is out of control, anxiety is out of control, and they just need that 24-hour care for the control of that particular symptom. And it's also something that once somebody is on general inpatient or GIP, that is covered by the hospice benefit 100%. So the care that that patient is receiving in the hospital, including room and board, in that situation, is covered 100%. But once the symptoms are managed and they're no longer in distress, then they may no longer qualify for general inpatient, but the patient still needs 24-hour care, and then they can receive hospice or are receiving hospice in the hospital or at the hospice house. They're, talking generically, there are hospice houses out in the community. Here in Vancouver, we have one. In Portland, I think there is one. The one in Vancouver is called the Ray Hickey House. And we can certainly do general inpatient there, or if the patient is still in those final days to hours, maybe in the last couple of weeks, but they're no longer in that crisis that requires the general inpatient, then we can see them for what's called routine care, but either in the hospital or at the Ray Hickey House. But there is a room and board fee. So, not to kind of muddy the waters, and I won't talk about that a whole lot. But again, to answer the specific question, general inpatient, to do the summary, it's usually that crisis. We're trying to manage a symptom. It's requiring that 24-hour care. And we usually see that really in the last days to hours to days of someone's life, maybe a little bit longer, but not too much. And that is usually covered by the Medicare benefit for hospice 100%.
Or if they're in pain crisis, or if they have had an unrelated injury, such as a fall with a broken hip, something like that. Is that under GIP, or are they discharged from hospice for that purpose?
No, actually, so back to kind of that philosophy of care. Boy, you're not starting off with the easy questions, are you, Lynn?
I'm reading my questions here.
So let's go back to the philosophy of hospice. So, Dr. Tang was talking about, going through that door, right? And, on the A team, everything is on the table, and any kind of treatment, really. Once you go through the door, you're on team B. We're talking hospice. Usually that philosophy of hospice is, symptom management. And we're no longer really doing the treatments. So no more poking, prodding tests. Usually patient isn't going to the hospital because we're not doing treatments anymore. Now, I want to be careful that that's not considered a blanket statement, because we want to remember that, if we have these symptoms and we're not treating the symptom, we're just providing symptom management, there are instances where a patient can go to the hospital. The umbrella of hospice is, comfort care, right? And so so to use the example specifically, if somebody falls and fractures a bone, fractures a hip, a femur, something like that, well, that's going to cause discomfort. So that is actually a scenario where a patient could go to the hospital. In fact, when somebody is on hospice, one of the first things that we are telling the family and the patient is that, if there is a change of condition, or if you have a question, or if something happens, in the situation where you would call 911, you would actually contact the triage nurse. And the triage nurse would do just that. Each hospice agency has a nurse that's on 24 hours a day, and actually has a provider on, I think, 24 hours a day. So the nurse would say, oh yeah, you've fallen, a fracture. Let's have your loved one go to the hospital so that they can get an x-ray, so that they get some pain control, so that we can make a determination that that the bone is or is not broken. But that is still something that a patient can do. if we saw a patient for, Parkinson's or maybe CHF, and there is an exacerbation for CHF and congestive heart failure, then that would be a situation where the patient actually wouldn't really be able to go to the hospital. Typically doesn't go to the hospital because that's part of the symptom, and Medicare doesn't will cover that fall with a fracture, but they wouldn't cover the patient going to the hospital to seek treatment, if that makes sense. But it will cover, if somebody has had a fall and a fracture, or perhaps something that's not related to the disease or the diagnosis. And that's why you want to call the triage nurse, because in some cases it is case by case, and you want that clarity. And I can't necessarily say, specifically in each situation, when would somebody be able to go to the hospital? So you would call the triage nurse and make that determination, because there are definite times where you can't. And keep this in mind, to add another layer to that. Once you're on hospice, and this is a myth that I always want to bust, once you're on hospice, you can actually decide, maybe you've been on hospice for 3 months and you've made the determination, I don't want to be on hospice anymore. And you can revoke or cancel hospice. I've changed my mind. I want to seek treatment again. And you can do that fairly quickly. Again, let's take a scenario where patient's on hospice and there is some kind of crisis or exacerbation, and you call the triage nurse. This is what's going on, and I want treatment for my loved one, or I want treatment for myself. And then you can actually revoke or cancel hospice. And the reason why we would do that is if a patient goes to the hospital and the hospital is not aware that the patient is on hospice and treats something that is related to their hospice diagnosis, then they potentially and likely could end up paying for that hospital visit and stay, and we don't want that. So contacting the triage nurse to have that discussion is like super important, and that's what you'd want to do.
Okay.
How's that? Is that clear as mud?
No, I think that was helpful. Amanda?
Can I just add something?
Yeah.
I thought that was a great description of GIP, Michael. I would just want to add that the GIP stay does not happen very often. It's not a very common thing. And so to give a person a picture of really what GIP looks like is we have a patient in the home with a caregiver, and suddenly or gradually a symptom is developing until, like Michael said, it's out of control. And so that might be pain, or it might be difficulty breathing, with confusion,
anxiety,
and so
especially with demented,
Yeah.
anxiety with
anxiety,
Alzheimer's. Yeah.
And so it's kind of out of control, like Michael was saying. So the nurse comes to the home, the hospice nurse comes to the home, and she will try the first medication, step to address that, and with working with our doctor. And then if that doesn't help, then she'll try the next one. And if that doesn't help, then the team will start talking about, is this a GIP case? Do we need to send the patient to a facility where they'll be monitored 24 hours, like Michael says? But GIP doesn't happen very often. And the whole point of hospice is that the care is home-based. And that's only one instance where a person might leave the home. The other instance is a respite stay, but otherwise the care is provided in the home. But Michael, that was a great description of GIP, I think.
No, thank you. One thing that I would like to add to that GIP conversation is, Amanda is absolutely correct that we don't see it that often, and I think when we do see it is when the the referral for hospice comes in very late in those final days to weeks. And it doesn't give the hospice team a lot of time. If we get a referral within the last 2 weeks of life, it just does not give us a lot of time to do the symptom management and to get on top of everything and to control that as much as it would be, 3 or 4 months, prior to, getting somebody admitted 3 or 4 months before, the 2 weeks that I'm talking about, the 2-week window. And plus, having the time and the opportunity to meet with the patient and the family and earn their trust and develop a rapport and a relationship. That's so important. And, we don't talk about that as much as we should. But and this has been my soapbox. So if I'm deviating from GIP a little bit, I apologize. But to get, it behooves us and benefits us so much if we can get somebody on services sooner than later, and especially when it comes to controlling or avoiding or mitigating, maybe that's the best word, the GIP scenario, because it really is. I've seen that. And when a patient is having issues with pain or anxiety and it's out of control, the family has issues with at least anxiety and their own pain. And it just makes life so much easier for the patient, the family, and the team if hospice is initiated sooner than waiting until the last 2 weeks of life. I had a social worker that I did a presentation with a team who was, when I said that hospice is it's a 6-month benefit, and we don't have to, we're not serving the patient's needs if we're waiting until the last 2 weeks of life to even present that. And the social worker said to me, well, thank you, Mike. I had always thought hospice was really for the last 2 weeks of life. And it's like, whoa. So, since then,
I'm really glad that you mentioned that, because I think that's an important thing for people to be aware of, for sure. Amanda, because of the fact that we have Kaiser here and we have so many Kaiser clients who are in our support groups, I wondered if you could just speak a little bit to how hospice and Kaiser work, because it's kind of specific or feels specific. And it's one of the things that I don't know much about, so I would love to hear your take on it.
Sure. So for hospice, when a patient is a Kaiser member, it usually they are either first on our home-based palliative program, and then the palliative care program connects with us as hospice, and we do an assessment to pick up the care of that patient at the end of life if they have a prognosis of 6 months or less, which doesn't mean they necessarily only have 6 months. They may have less than 6 months, or they may have a bit longer than 6 months. And with hospice, we are always regularly intervals of checking to see that the patient still qualifies and still eligible for hospice. Sometimes a patient might improve somewhat and kind of stabilize for several months. And at that point, we would talk to the family about maybe they're not really quite at the point where they need a hospice, and they can come back later on as needed. But so we get our referral for either from a primary care provider, or a Kaiser provider, or from our palliative program. And then what happens is our office makes an appointment with the family, and we have an admission nurse. The admission nurse will go out to the home, and they will do a complete assessment And they do use that FAST scale that Dr. Tang showed on the video a while ago to assess a dementia patient and to see if they're at that point where they really could benefit from the care of hospice and be eligible for hospice. Once a patient is on the hospice program, then the nurse usually visits at least once a week. That can go up or down depending on the patient's need. The patient might go through a period of time where they only need once a week of a nurse visiting. And when the nurse comes, she is looking at medications, seeing what refills need to be ordered, checking on symptoms. Symptoms meaning any kind of change in a patient's pain or mental status, increased confusion or difficulty breathing, or even constipation, just any kind of uncomfortable symptom. And the nurse is right on top of that with the hospice doctor to assess what would help with that issue. Then, of course, the social worker also is seeing the family. They could be seeing the family. It varies depending on the family, how much the social worker is involved. But because we go with the family's wishes. But when the social worker meets with the family, they're there for support, emotional support, also for end of life resources. Like Dr. Tangs and Mary Buckland talked about, the advanced planning documents, legal resources for legal resources, such as connecting to a lawyer if that's needed for end of life legal and financial planning. And then we're also there for connecting with the VA when we've got a veteran who is in our care. We are connecting with the VA to see how, if there are any benefits there for the patient. And then there's a chaplain, as I mentioned, and he goes in. We have a man who's our chaplain, and he is there for spiritual support for those that would like that. And then we have a bathing aid, and the bathing aid can help with giving the patient either help with a shower or a bed bath. If it's not safe for the patient to get up and walk to a shower, then our aides can do a bed bath. And sometimes we have a volunteer too who can make a friendly visit once a week for an hour or a couple of hours, and that will give the caregiver a little break. Also on the hospice benefit, just also to clarify, there is a difference with payment. Of course, palliative care is an insurance program. A health insurance pays for that, but hospice is covered by Medicare, so that's a Medicare benefit. And so Medicare made up what is in the hospice package and what is not. And they put in a respite benefit, and that's a 5-day stay in a facility for a patient to give the caregiver a 5-day break. But the patient has to come back home on the 6th day. And right now, unfortunately, those respite stays are hard to get because our lovely community hospice facility that we had is not open. So there is just the Ray Hickey House. And then I believe the Woodland Care Center is helping with that a little bit, but we have to really work on finding respite places. They're far and few to find right now. But that gives you a picture. Yeah, that gives you a picture of the hospice benefit, really Kaiser or any other in-home hospice benefit.
I appreciate you going through the benefit because that is in order to be a hospice program, you have to provide those items. And that was one of our questions was related to respite. Is if I need respite and hospice says there's no respite available, what do I do?
Yeah, that one's a little bit difficult. we've contracted with quite a few different skilled nursing facilities to provide respite services in the Vancouver and area, as well as up in the Cowlitz area. So it's really just these local skilled nursing facilities having those rooms available at the time of need. Usually, if we have a good amount of time for a respite, say a couple of weeks for our social workers to look into starting to get that organized, that gives you a good amount of time to get a respite approved. A lot of times a respite can be planned that way. And I know sometimes emergencies happen and it needs to happen quickly. So at that time, sometimes our hands are tied and we have to travel a little further than we would want to have a patient placed in a respite at that time, whether they're here in Vancouver and have to go up to Woodland. Sometimes the Canis at Prestige we have contracts with them as well. So there's different skilled nursing facilities that we contract to get that arranged, but we need a good amount of time frame to make sure that that can happen. And then you do have to keep in mind that you may have to place your family member a little bit further on those emergency times that come up.
So is that consistent with Kaiser and Peace Health as well, related to contracting with facilities?
With Kaiser, it is. Just one additional thing about respite stays for a patient who has dementia. If the patient is having behaviors where they need one-on-one kind of supervising, then respite really is not a good fit, because a lot of these facilities do not have staff to be monitoring a patient's behaviors and making sure they're safe and not falling and that kind of thing. So there are quite a few limitations to that respite benefit, but when it works, it's really helpful for the caregiver.
Question about why are some hospices doing research every 30 days? Families have described this as being on pins and needles every month, waiting to hear if they lose all their help.
I haven't heard of anybody doing 30-day research. So that's interesting to see. The only thing that I could think of is a 30-day research is if the patient is really, really getting close to not qualifying for hospice any longer. But even then, our rules and regs say 60, 90.
I was going to say.
Right. Yeah.
So
I think that's the same for us. So
okay. I can't give you detail on that question. That was just a question that was asked. Sorry about that.
no, that's okay. And please, if somebody has had a direct experience, at least with Peace Health, and that was what they were told, please let me know that, and I will be more than happy to do a little follow-up and research. But that's my understanding. That's not our policy.
And always remember, there's multiple hospice agencies, Kaiser, Peace Health, Eden, in the area. And if you are feeling like the company you're working with isn't meeting or exceeding the needs that you have, and you need to be reassessed by another company to see if that's going to be beneficial to transition to a new company, you can always do that. There's that freedom of choice. So always reach out to your hospice agency, talk to them, let them know what's going on. Give them the opportunity to correct whatever issues are at hand. And if you don't feel like that's working for you, then maybe you need to reassess and see about getting another team in there to help you out. We all work in this environment together. We're all here to help you and make sure that moving into a hospice focus of care is comfortable for you and your family. And the last thing any of us want to do is make you worrisome or uncomfortable with the service line. And so there's lots of people out here to help you through those processes. So with that 30-day making you anxious, reach out to your hospice agency, ask questions, see what's going on, give them the opportunity to correct it. And if last case scenario, you need to talk to somebody else, feel free to reach out to any of the liaisons or hospice agencies to talk as well.
And one thing I would add to what William was saying, giving the hospice agency a chance to correct. If you are, if you have a team member, whether it be a nurse or social worker, that is just not connecting, you can actually ask for a different nurse or a different social worker or whomever the provider is. You have that. Keep in mind with healthcare, at least when it comes to home health, hospice, and palliative care, the patient has the right to choose. And so if you don't like the nurse that you're working with, request another one. If you don't like social worker, request another one. If you don't like the agency, request another one. And that should be fulfilled.
Is hospice and palliative care available for the homeless?
Hospice definitely is. We do service the homeless and the homeless populations depending on where they're at and where their location and if they're going to be secured into that one place.
Right.
I've had people who have been in automobiles or in tents who will receive services from hospice. Maybe they won't receive all service lines. I can't send a CNA to do a bath in a car or anything like that. But we do have nursing that can come out and do their visits and do their assessments and monitor the patient, and the social workers as well to visit and help correct that homeless issue if at all necessary, to see if we can find some placement options and some other options to help them through their journey, because the last thing we want is somebody on the road going through that by themselves when you have resources available for us to be able to help that individual have a good quality of life through their transitional period.
Thank you. That's kind of nice to know, to hear. How much decline do hospice companies need to see in order for a patient to be able to stay on hospice?
So it doesn't have to be. Go ahead, Michael.
Oh, no. Well, I was just going to say I think where you were going with this, there doesn't have to be a lot of decline. We just need to be able to document that there is a change somewhere in the mobility or the physical side of things, or the patient is eating less or drinking less. We just need to be able to prove or document objectively that there's a decline or a change, but it doesn't have to be super significant. And then we can keep somebody on hospice, for beyond the 6 months, as long as we can document that there's a change. We've actually had patients on hospice for a couple of years. There's just been that slow, steady decline. We can document it. It's verifiable. It's objective. But it doesn't have to be a significant change or loss in function.
Yeah, like Dr. Tang's slides were showing, there's just that steady decrease that needs to happen. That's why we say getting onto hospice sooner than later is the best way to have this benefit work well for you, because you'll have a patient, for example, in the hospital who's in a critical condition, who's really having a difficult time and is hospice appropriate. Discharge home on hospice services. And then once we get them home, we get them on a good med regimen. We have a good nursing program in place. And we start to see this patient either kind of plateau or just slow down their decline. Whereas you've seen them usually with hospice patients or, with dementia patients, you'll see them steadily decline, then hospitalization, and you'll see that drop. And then they won't go directly 100% back to where they were this time before, because every time they have that incident, they're just a little bit less than the person they were before. And you'll see that consistently. And so monitoring that descent is really what we do. And it doesn't have to be large. It just has to be continuous. And then when you do see those people who do have a bounce back and they start assessing and say, oh, they no longer qualify for hospice, because now maybe they have that good regimen in place, they have that nursing care in place, and they've actually started to plateau and get, stay at just a straight line, and they're not meeting those Medicare requirements of a decline of 6 months or less. And that's when they graduate off of hospice services. Not to say that hospice service benefit isn't available to them again, because once that person does graduate from hospice, if they're no longer eligible, it just takes that one incident for them to become eligible again. And then you contact us and we're back out there evaluating and have them right back on services again. You know, it's not just you're on hospice and that's it. It's a benefit that's available because there's that decline in terminal illness, and we want to make sure that you are comfortably transitioning through that process. And if hospice isn't the benefit that's going to work for the patient at that time, then we need to go back to aggressive treatments and traditional medicine.
So I'll give a concrete example. So I see a patient with dementia and there's agitation. Patient lives in memory care. So if you go to the FAST scale, which I'm happy to pull back up. Let's see. Let me do this. So here, if you go to this FAST scale, if the patient has nothing else except dementia, like they are led a good life and they have nothing except dementia going on, you have to get a state of 7C to walk through that hospice door, in addition to the goal of comfort. So two things, right? You need a diagnosis, and then you need the personal goal of a natural end of life and comfort focus. Most of my patients never go to hospice only on dementia. What in actuality happens is they might be functional assessment scale FAST level 6E or 7A, but they were admitted for COPD. They were admitted for a heavy infection called sepsis, and they tank. They tank in 4 weeks. They try to go to rehab, but they don't quite make it back up. And so now their functional status is more akin to down here, like 25%, 30%. Before they went into the hospital for sepsis, they were like 50% and having dementia. So that really short period of time that Michael and William was talking about is like 3 months, 1 month. If I can document in the chart, patient has lost weight, is fragile, bed bound, not eating as much, in addition to decrease of 30% functional status in a short amount of time, that gets them through hospice because of the trajectory of decline, the expected continued trajectory of decline. So what Peace Health will do when I send my referral to the medical director of Peace Health is they will take the patient on a conditional basis and say, all right, let's take the patient on for a month. If the patient continues to show expected decline, that person stays on hospice, even though they're nowhere at 7C, because we know that 6 months is going to happen, not because of dementia, but because of that sepsis, because of that CHF, because of that COPD, et cetera, because there's a wound from diabetes. It could be anything. As William said, and Michael said, if at 1 month, suddenly they're eating again for some reason, and they look like they're going to live, they don't need to be on hospice. They can go back to the community. They can go back to Team A. That doesn't always happen. If they do graduate, it might be another 3 months. They'll get sick again, and then they will be readmitted to hospice. So that's why you need a palliative care practitioner to do some of these assessments and to guide the family, because left to your own devices in the ER, in the hospital, they're all great physicians, they're all great practitioners, but they don't know the nuances of how you should be on Team A or Team B. Those guided conversations are what Mary and I and the social worker and the hospice referral specialist talk to families about. if I were not a specialist and I was doing purely family med, I wouldn't know this stuff. I will out myself. When I was in residency, I had a stage 4 cancer patient that was 93. It never crossed my mind to send him to hospice. And I feel ashamed because it is clear as day to me now that he should have gone to hospice. But I kept him. I kept him until he was so gorked from all of his pain meds and his metastatic disease. And then he passed out. And then they took him to the ER and he had like 5 fentanyl patches, not because he was trying to overdose, but because he forgot. He had dementia and he forgot that he had put them on his body. And the family wasn't paying attention because they were trying to keep him independent. And they ripped it off and he had like 5 patches. And so I will forever remember that. So you need specialty palliative care. You need these guardrails in order to make sure that your hike is smooth to the waterfall.
We have 5 minutes, and I would like to give each of you a minute to tell people what you wish everybody knew. So, Amanda, start with you.
I think I'll just repeat what Michael said. It's very important, and everyone was nodding their heads, but it is hospice referrals don't need to be in the last 2 weeks of life. They can be well ahead of that, as long as a doctor has said that the patient has a prognosis of 6 months or less. It's great if they can come on to hospice as soon as possible and get the benefit of the whole team to cover through all the time that is left, and support the family and help the patient with that. The other thing is, I did want to give a little resource. People maybe have heard of Atul Gawande's Being Mortal, the book, and I just recommend that to everybody to take either the audiobook or read the book. It just has a lot of the information we've been discussing here, but from a perspective of a doctor and his own family and the path that he took, which is a wonderful book and with a lot of good information. So I would recommend that.
I'll send
What's
that
the name of the
resource
book
out.
again? Oh, sorry. Okay.
It is
Mortal.
Being Mortal by Atul Gawande.
Dr. Tang.
I feel like I already gave my last word, but I'll say one sentence. Advanced care planning is not about the piece of paper. It's about the process of conversation over time.
Perfect. William.
I would like everybody to know hospice is a benefit that's available to everyone. And you don't have to wait for your doctor's visit. You can contact a hospice agency to discuss moving forward with hospice prior to that. So if you ever need or feel that hospice is the direction you want to go, you can always reach out and we can meet with you regarding what service line you feel is best for the family.
Michael.
Like Amanda said, that's my soapbox, is just not waiting until the last 2 weeks or 2 days for that matter of life. And that you have a voice and to utilize it, and don't be afraid to talk to your doctor about, is it now appropriate for palliative care? Is it now appropriate for hospice? And that's a good conversation to have. To Dr. Tang's point, not all doctors are created equal, and not all doctors feel comfortable about having those conversations, and may just sit on it until somebody else brings it up.
The primary reason back when I was a palliative care nurse that I would get referrals so that I could have the discussion. Mary Buckland.
Sorry. We're all going on this journey called life. we're all going on different roads. Everybody's journey is a little bit different. We all have a little bit different roadmap. In palliative care and in hospice care, we can really function as the GPS as detours come along the way. One thing that I've learned in my I hate to say 36 years in medicine is we can do a lot of things to people in medicine, but I think we also need to really empower those around us to ask the why are we doing these things? What would the end result be of these things? And is it really what the person wants? Empowering that person and their voice and their wishes as they're going down this thing called life down the road.
Thank you. Thank you all so much. This was wonderful. I just appreciate you taking your time after a long day's work.
Thank you.
So thank you all.
Thank you.
Okay, thank you.
So just before everybody leaves, I want to remind you all that in a couple of weeks, instead of doing our community education for the Christmas holiday, we'll be having a program called Jingling for Hope, which is actually a music program. It will be at Bridgeview Resource Center, and everybody and their loved ones who have dementia are welcome to attend. And we'll have a music therapist there with his guitar and his harpist, and we'll have cider and cocoa and cookies, and everybody's invited. So please come. Happy holidays, everyone.
Happy holidays.